Dr. Schultz is a licensed psychologist with Norton Children's Behavioral and Mental Health, and she also provides inpatient consultations at Norton Children's Hospital. She is an assistant professor at the University of Louisville in the Division of Child and Adolescent Psychiatry and Psychology, where she is also the director of training for a pre-doctoral child clinical and pediatric psychology internship program. Dr. Schultz currently serves as the Child and Adolescent Section Representative to the Kentucky Psychology Association Board of Directors. Dr. Schultz earned her bachelor's degree at Tulane University and her master's and doctoral degrees in clinical psychology from the University of Mississippi. She completed her internship and fellowship in pediatric psychology at the University of Louisville School of Medicine. Dr. Schultz's clinical interests includes adolescent mental health and chronic illness coping in youth. So please welcome Dr. Schultz.
Thank you so much, Dr. Kingery. So I'm going to share my screen. Today, I will be talking about the mental health aspects of diabetes, especially with considerations for pediatric populations. I have no conflicts of interest to disclose. Learning objectives for my presentation are to summarize the importance of comprehensive care in the management of diabetes, to discuss psychological comorbidities with diabetes, and to describe how psychological comorbidities may impact adherence to the medical regimen as well. So I'll start here with the ADA guidelines from 2021. And you'll notice here that in the guidelines, there's consideration for mental health. And so the importance for screening for depression, anxiety, and disordered eating, considering assessment for cognitive impairment as well. And so we know that by these guidelines, mental health is something that we need to consider. And so hopefully we'll talk a little bit more about the importance of doing that today. So comprehensive diabetes care is immensely important. And so the American Diabetes Association and the International Society of Pediatric and Adolescent Diabetes indicate the importance of psychologists and mental health in diabetes care for youth. And so starting in the year 2000, we start to see these guidelines emerge that indicate the importance of considering mental health and having that be an important part of comprehensive diabetes care. And so recommendations for comprehensive care indicate that people with diabetes can benefit from a coordinated multidisciplinary team that may draw from diabetes care and education specialists, primary care providers, subspecialty providers, nurses, dietitians, exercise specialists, pharmacists, dentists, podiatrists, and mental health professionals. So when I talk with patients with diabetes, I always indicate that diabetes is kind of like a team sport and that it's not something to be done by themselves, but it's something that's really important to rely on the people and the team of support that they have around them. So the American Diabetes Association recommends that mental health professionals be considered integral members of the diabetes multidisciplinary team. And psychosocial care should be integrated with a collaborative, patient-centered approach and provided to all people with diabetes with the goal of optimizing health outcomes and health-related quality of life. And so why is comprehensive care so important when we talk about our patients with diabetes? And so it's really important to consider here, so Bronfenbrenner's model, that individuals don't exist in a vacuum. And so really when we're talking about youth, they exist in multiple systems. So they exist within their family and within their community. And so keeping those things in mind in order to provide care that really looks at the whole patient. Aspects of comprehensive care. So multidisciplinary team approaches can improve self-management, glycemic control, and quality of life. Mental health professionals are most effective when they have knowledge of diabetes and work closely with other diabetes team members. And so having mental health professionals who understand what a CGM is and what an insulin pump is and how those things might impact day-to-day living for patients. And then behavioral health services include mental health, but they also include behavioral medicine services. So this will include mental health, so what we think of when we think about treatment for anxiety and depression, but also behavioral medicine is a critical component here. So behavioral medicine would include services designed to intervene on physical health using behavioral means. So examples of this would be health behavior change programs, education for coping with a chronic illness, programs to improve adherence to medical regimens, and services that access the relaxation response. So things like relaxation training or biofeedback. And we know that there's a relationship between mental health and physical health. So effective behavior management and psychological well-being are foundational to achieving treatment goals for people with diabetes. And there's a bidirectional relationship between mental health and physical health. So mental health and physical health impact each other. So if we have a patient who is stressed, this could potentially exacerbate their health symptoms. If they're not taking care of their physical health and they have reduced energy, we can expect a negative impact on their mental health. So they impact each other. So to truly treat physical health, we need to make sure that we're treating physical health and mental health concurrently. Mental health comorbidities can impact adherence to treatment, resulting in increased risk for complications. And again, we need treatment for both mental health and physical health to adequately treat our patients. So when we talk about diabetes and mental health and what's included, it's important to note that in patients with diabetes, there's an increased risk for a number of conditions. So there's an increased risk for anxiety and for depression. So adolescents with type 1 diabetes are at a 2 to 3-fold increased risk for the development of depression and anxiety. Anxiety and depression will have a negative impact on the frequency of blood sugar monitoring and glycemic control. In addition, depression tends to lead to more hospital visits and admissions, as well as increased risk for complications. And it's associated with negative health outcomes and reduced quality of life. We also see increased suicidal ideation. So suicidal ideation youth with type 1 diabetes than the general population. Suicidal thoughts are also correlated with non-adherence to diabetes regimen. We see an increase in eating disorders and disordered eating behaviors. So disordered eating behaviors are more common, especially in adolescent females with type 1 diabetes than adolescent females without. And then we also see an increased risk for diabetes distress, or what we commonly think of as diabetes burnout. So even if an individual is not meeting clinical criteria for anxiety or depression, diabetes-specific emotional distress results from constant behavioral demands of diabetes. So in talking with patients with diabetes who are encountering diabetes distress, I often point out that having diabetes is like having another job. And so managing all of the aspects of diabetes care. So over half of surveyed teens reported at least one serious concern related to living with diabetes. And those with diabetes distress also report reduced quality of life, increased family conflict, and it's also associated with a higher hemoglobin A1C. So thinking about all of the aspects involved in managing diabetes, I really like using this pictorial description. So I work a lot with teenagers. Teenagers understand things when talking with emojis or with texting. And so this helps to describe what having diabetes is like. So we see what having diabetes is like on this top part of the picture. So an average day living with diabetes, we'll see here a number of emotions depicted, having to do insulin injections, the implications of having a high or a low blood sugar indicated here. Whereas if we look at everyone else, we might see more neutral emotions. And so again, having that understanding of what it is like for our patients living with diabetes. So the American Diabetes Association has indicated from a position statement that we know that individuals who have diabetes are going to cope with that in different ways. And some individuals may experience things that are going to be on a continuum. So some things may be non-clinical, and so they may have some difficulties, but overall are coping well. And on the other end of the continuum, we have individuals who are experiencing clinical symptoms. So those that are more indicative of an adjustment disorder or anxiety or depression. And so it's important to know when we need to refer to a mental health provider for further evaluation and treatment. So some of those things would be if a person has a positive screen for anxiety or for depression, if there's a serious mental illness that is suspected. And so just a number of things to keep in mind about when we might need to refer. Obviously, if there are safety concerns or things like that, we would want to make sure that we're referring to a mental health professional for further evaluation and treatment. So let's talk a little bit more in depth about the mental health diagnoses that are comorbid with diabetes. So first, when we think about anxiety, there are a number of anxiety disorders that we may think of when we think about anxiety. And so this could be generalized anxiety disorder, where an individual might be worried about diabetes, but they might be worried about school and their family and a number of other things as well. We might see panic disorder. We might also see adjustment disorder with anxiety. We might also see that a patient has a specific phobia of needles or a fear of hypoglycemia. In addition, anxiety symptoms can overlap with symptoms of hypoglycemia, making it hard for a person with diabetes to differentiate between symptoms of anxiety and low blood sugar. So what do we do? If we have a patient with anxiety, what are the treatments that might be helpful for our patients? So the first one is going to be cognitive behavioral therapy. So cognitive behavioral therapy is based on the premise that thoughts, emotions, and behaviors are all related to each other. And so with anxiety, we're going to try to challenge thoughts to help our patients with anxiety. Oftentimes for anxiety, a combination of therapy and medication management can be very beneficial. Relaxation training can be beneficial for patients with anxiety, as can exposure or systematic desensitization. So if we have a patient who is fearful and have a phobia of needles or fearful of other things, we want to make sure that we are safely exposing them to the things that make them fearful in a very systematic way in order to make sure that they are not so anxious that they're avoiding, and then that avoidance then maintains the anxiety. So we want to make sure that we're engaging in exposure of those feared activities. In regards to diabetes and depression, there are a number of depressive disorders we may see. So major depressive disorder or persistent depressive disorder, as well as adjustment disorder with depressed mood. And it's important to note how depression can impact diabetes care. So individuals with depression tend to have decreased motivation. They also have problems concentrating. And so if a patient has depression, diabetes can be harder to handle and their blood sugar tends to rise. And then again, with higher blood sugar, it's harder to escape depression. And so it ends up in a very unhealthy cycle. It's also important to note that there's an increased prevalence of suicidal thoughts, plans, and attempts for patients with diabetes. We also want to be mindful that insulin, while it is life-saving for our patients, can be potentially harmful in individuals with increased thoughts of suicide. So something to be very mindful of. In regards to diabetes and depression and treatment, so again, cognitive behavioral therapy is very beneficial for depression. So CBT, we know from research, is the thing that's most beneficial for treating anxiety and depression. And again, a combination of therapy and medication management offers benefits as well. And it's important to consider if a safety plan is needed to maintain safety of our patients. In regards to diabetes and eating disorders, again, disordered eating behaviors, and this can include disordered eating behaviors that don't quite meet what we would normally think of for an eating disorder of anorexia. And it also includes binge eating disorder. And these are more common in females with diabetes. It's also associated with worse glycemic control, more health complications, and higher mortality rates. And again, when thinking about the importance of considering our patients in context, I bring up Maslow's hierarchy here because I think it's really important for us to consider not only how our patients are handling their diabetes, but also how they're functioning in other domains. And right now that includes the COVID-19 pandemic. So children tend to thrive when they are safe and when they are protected, and when their family and community connections are safe and stable. And it's important to note that the COVID-19 pandemic is disrupting every aspect of a child's life. So it's impacting their health, their development, their learning environment, their family setting and economic security, their protection from violence and abuse, as well as their mental health. And so considering that all of our patients are coping not only with diabetes, but in the midst of a global pandemic, it's important to note how mental health is being impacted during this pandemic as a whole. So when we think about all youth, those with diabetes and those without, right now we are seeing an alarming shift. And so we are seeing increased anxiety. So one recent study found that 77% of all youth are reporting worry, and especially about disease or death, and worried about infection from the pandemic being unstoppable. So we're seeing an increase in anxiety. We're seeing an increase in adjustment disorders, acute stress disorders, or PTSD. We're also seeing an increase in depression. In addition, we're seeing an increase in grief. And so 175,000 children in America have lost a parent or a primary caregiver to the COVID-19 pandemic since the beginning of the pandemic. And so the children that we're seeing may have diabetes, but they also are coping with the pandemic. And so a recent study that looked at private health insurance claims. So compared to 2019, in 2020, we're seeing individuals aged 13 through 18 have a tremendous increase in generalized anxiety disorder, major depressive disorder, and adjustment disorders. So all three of these, so generalized anxiety disorder and depressive disorders and adjustment disorders, are things that we already see in our patients with diabetes. And so knowing that this has increased drastically during the pandemic. We're also seeing an increase in eating disorders as well as PTSD. So it's important to note that most mental health disorders begin in childhood. And what the pandemic is doing is that in individuals with a current mental health condition, it's exacerbating those symptoms. And in individuals without a mental health condition, it may be creating a mental health condition. So again, we know that our patients with diabetes are already at an increased risk. And so being mindful of how the pandemic might be exacerbating that risk for them. So again, we're dealing with our patients who have chronic health needs during a pandemic, which may be exacerbating that anxiety as well. In October, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association declared a national emergency in child and adolescent mental health. So we know that this is impacting the youth in our community in unique ways, and just want to be very mindful about mental health needs during the pandemic. So I also want to talk about when behavioral health can impact diabetes care. So we know care for new onset diabetes patients is critically important. So the American Diabetes Association recommends assessing psychosocial issues and family stresses at diagnosis, as well as during follow-up care. And again, this is where the role of the multidisciplinary team is so important to make sure that we are assessing for any barriers to care. And that adjustment to the new diagnosis, both for patients and for families. Patients may present with anxiety, depressed mood, disturbance of emotion, and/or conduct. And so we really want to make sure that we're normalizing that adjustment and the associated emotions that come with that, and providing collaborative problem solving and behavior management. Outpatient screeners are immensely important. So the American Diabetes Association Standards of Care guidelines recommend screening for psychosocial distress and mental health problems. And so screening for anxiety and depression can be done with the PHQ-9 or the GAD-7. And so making sure that we're assessing for anxiety and for depression in our patients. It's also important to note diabetes and quality of life. So one quote says that the chief business of a chronically ill person is not just to stay alive or keep symptoms under control, but to live as normally as possible despite symptoms and disease. So we want to make sure that our patients have a very strong quality of life. So successful management of chronic health conditions must focus not only on disease control, but also, and perhaps more importantly, on supporting individuals and their families to live happy, healthy lives with diabetes. Care has shifted towards a patient-centered approach and behavioral approaches to living with diabetes. Periodic monitoring and discussion of health-related quality of life in adolescence is appreciated, and it has positive effects on psychological well-being, except for those with the poorest control. It's also important to note about diabetes and technology. And so there are so many positive aspects about technology for our patients with diabetes. I always tell them, though, it's a personal choice because it's really about fit for that patient and the family. So there are positive and adverse psychological effects related to the use of continuous glucose monitoring, for example. So there are so many positives to CGM technology. So improved quality of life, reduced stress and anxiety, greater peace of mind for patients and for families, greater sense of normalcy, better detection of hypoglycemia, and better glycemic control. However, some individuals report feeling overwhelmed by the data, feeling more stigmatized by having to wear technology, increased anxiety or burden due to greater awareness of glucose levels, families with impacted sleep, and then pain and body issues. So again, important to note different considerations that we may see with our families who have patients using technology. We may also see non-adherence to diabetes care. And so this may result with diabetes distress or non-adherence to treatment recommendations. So often thinking about patients in DKA. So with treatment considerations with non-adherence, we want to make sure that we're responding with a non-judgmental approach. So really taking a collaborative approach, and this is often done with motivational interviewing. And so taking a collaborative approach with our patients and really emphasizing the values that they hold. What is their motivation for engaging with their diabetes care? This involves setting attainable goals. So seeing where they are currently and setting goals that they're bought into that also seem attainable for them. We want to take a family approach to care and definitely encouraging parental supervision. And so encouraging a developmentally appropriate stance from a family about diabetes independence as well. And then we always want to make sure that our patients have academic accommodations in place to make sure that they are successful at school. And so, do psychological interventions work? So if we're talking about behavioral health and behavioral medicine and that approach, does it even work? And yes, it does. So behavioral interventions can improve diabetes treatment adherence, and behavior change specialists are most effective when they work closely with other diabetes team members. When comparing different interventions, psychological interventions are more effective than telecare or educational methods in decreasing hemoglobin A1C. Metabolic control of children in diabetes clinic who received a psychology consultation improved. And other psychological interventions, such as psychoeducational interventions that improve problem-solving skills and motivational interviewing, have been shown to improve glycemic control as well. So I want to call attention to helpful resources for providers. So I talked a little bit about motivational interviewing, and so these are various texts that can be really helpful for providers in incorporating motivational interviewing and interactions with patients. These are my references. And thank you so much for your time, and I'm happy to answer any questions if there's time.